Good morning, doctor. My name is Fu Yu Wei. My matrix number is 154597 and I'm from Group 2. My patient's information is Siti Shafiqa binti Nordin and her registration number is B298942. She is currently 24 years old, female, single and a student. These are my content. Introduction. Periodontal disease is a popular oral disease among Malaysians, experienced by 94% of dental adults according to National Oral Health Survey of Adults 2010. Gingivitis and periodontitis are common periodontal disease which are resulted from a complex interplay between dental plaque on tooth surface and host immune inflammatory response that develops in the periodontium. The main aim from treatment of gingivitis is to reduce inflammation. This can be achieved by using different instruments to remove the plaque deposits through appropriate brushing technique, flossing technique, and the proper ways to use mouth rinse. The removal of plaque and calculus is also professionally achieved by scaling and root planning according to the severity of the condition. For history, chief complaint. My patient was referred from KRK for restorative treatment and scaling. Patient came with complaint of gum bleeding while brushing her teeth and accumulation of calculus. For history of presenting illness, she complained of gum bleeding when brushing her teeth on lower right and left area and accumulation of calculus on the lower posterior teeth. There was no active pain. For past medical and surgical history, my patient has no known medical illness. She had surgical history of tonsillectomy when she was 12 years old, and there is no complication from the surgery. For past dental history, she is a symptomatic attendee and did not have any tooth extraction before. She brushes her teeth twice per day using fluoridated toothpaste. She denied of using mouth rinse and dental floss in a daily oral care routine. She uses a toothbrush with moderate bristle, and she brushes teeth using long horizontal stroke for posterior teeth and up and down for anterior teeth. She loves to eat sugary and drinks. There is no drug and allergy history. For family medical history, her father passed away due to stroke while her mother was still fit and healthy. She has 6 siblings and she is the youngest. All of her siblings are fit and healthy. For social history, my patient does not smoke or drink alcohol. She also does not abuse illegal drugs and chew bitter quid. She is currently a practical student in University Selangor. For clinical examination, extraoral examination. Her lips are pink and moist. There is no abnormality detected for nose and eyes. The face is symmetrical and no clicking sound, no tenderness and no pain for the TMJ, and no lymph node enlargement noted for the lymph node, and there is no salivary gland enlargement, no muscle wasting, and there is 3 finger opening for the mouth opening. There is no abnormality detected for the mucosa, frenum, hard palate, soft palate, and also the floor of the mouth. For the tongue, there is presence of hyperpigmented papules on the dorsum of the tongue. Otherwise, it is moist, pink, and good hydration. For gingiva, it is reddish, swollen, and slightly soft in consistency with loss of stippling features. For oral hygiene assessment, Sinus and low plaque index. The oral hygiene index for the patient is 0.8617, which indicates good oral hygiene. For basic periodontal examination, the BPE score is 2. For plaque and gingivitis record, the plaque score is 52% and the gingivitis score is 25%. For ICDAS charting, there is multiple caries for the patient, include 02 on 22, 23, 26, 27 and 37, 03 on 16 and 47, and 04 in 46. Other findings include spacing between upper and lower anterior teeth, specifically teeth 42 and 43, 32 and 33, 22 and 23, and 12 and 13. There is also midline diastema between tooth 12 and 11 and 21 and 22. For occlusal assessment, incisor relationship, the overjet is 0.5 mm and the overbite is 1 mm. Incisor classification is class 1. For permanent molar relationship, the right is class 1 and the left is class 1. For midline, upper midline coincide with facial midline and lower midline coincide with the upper midline. For investigation, I took posterior right and left bite wing radiograph, and the alveolar bone is at normal level as there is no bone loss seen in the radiograph. There is no any supra or subgingival calculus seen. The radial opacity indicates restoration on the tooth 17, 36, and 46. And there is radiolucency on tooth 24, 35, 46, and also 47. For definitive diagnosis, first, mild generalized plaque-induced gingivitis. Second, caries 03 on tooth 16 labia and 46 occlusal and buccal. 3. Caries 04 on tooth 46 occlusal. And number 4, spacing between upper and lower anterior teeth. For treatment plan, initial phase or control phase. First, oral hygiene instruction, motivation, and diet counseling. Second, full mouth scaling and polishing. And third, restoration on tooth 16, tooth 246, and also 47. Restorative phase. Refer the patient for orthodontic treatment to KPP. And maintenance phase. Review in 3 months. Treatment done. First visit, examination and analysis were done and left and right bite wing radiographs were taken and the oral hygiene instruction and that counseling was given to the patient. And during second visit, full mouth scaling and polishing were done and the patient's compliance was reviewed and the patient was compliant. Oral hygiene instruction and diet counseling were reinforced. And during the third visit, composite resin restoration of tooth 46. This is the pictures before the treatment, which is a scaling and polishing. And this is after. So we can see the comparison between these two pictures. We can see that the accumulation of plaque and calculus has been greatly reduced. What I have learned. First, scaling is good to be done in order to avoid omission. I did the scaling by starting at 9 o'clock for buccal surface of right posterior and lingual surfaces of left posterior teeth with my patient turning away from me, and followed by for buccal surface of left posterior and lingual surfaces of right posterior teeth with patient facing towards me at 10 to 11 o'clock. And the surface towards the operator on anterior are scaled at 8 o'clock for both buccal and lingual aspect, while the surfaces away from that are scaled at 12 o'clock. So I practice this type of scaling, this order of scaling every time I do scaling and polishing, so that I won't miss any part of scaling. Secondly, communicate effectively with the patient. Thirdly, find the most ergonomic position while examining intraorally or giving treatment to the patient. It takes time for us to find the best position and lighting. And more practice are required to master skill during the procedure using the mouth mirror without direct vision. And that's all from me. Thank you.